Hello and welcome to MicroPeds Talks from Pediatrics Deep Dive. Last time, we talked about strep throat, a condition that seems simple at first glance. But what if I told you that, left untreated, it could trigger one of the most serious complications in pediatrics? Today, we dive into acute rheumatic fever, ARF, in children.
That's right. And acute rheumatic fever, it isn't just something from the history books. It's still incredibly important, importantly preventable. It's a major cause of cardiac disease, especially in low-resource settings around the world.
It affects millions, right?
Right.
And it's still a leading cause of cardiovascular death early in life in some places.
Tragically, yes. We're talking the first 5 decades of life. Now, its incidence is much lower in, say, the U.S., Canada, Western Europe.
Yeah, you don't see it nearly as often here.
Correct. But it definitely still occurs. And recognizing it is absolutely vital because, well, early intervention can completely change a child's outcome.
So let's break it down. What exactly is ARF?
Okay, so fundamentally, ARF is an inflammatory condition. It's not a direct infection in the heart or joints. It's a complication that follows a group A streptococcus, or GAS, throat infection.
Laryngitis, yeah.
Exactly. And the timing is key here. It's what we call a delayed sequela. It doesn't happen right away.
So not during the strep throat itself.
No, typically it shows up about 2 to 6 weeks after the strep throat resolves. Now, for one specific manifestation, Sydenham, Chorea, that delay can be much longer, sometimes even 1 to 8 months later.
Wow, that's a long lag time. And I guess sometimes that original strep throat was really mild. Or maybe the family doesn't even remember it happening.
That happens frequently, which is why relying on serologic evidence looking for those strep antibodies like ASO or anti-DNase B becomes so crucial for diagnosis. You need proof of that preceding GAS infection.
Makes sense. Let's talk epidemiology briefly. The global picture is pretty sobering.
It really is. Globally, we estimate around 470,000 new cases of ARF each year. And sadly, about 320,000 deaths annually from its main complication, rheumatic heart disease, or RHD.
And the age group most affected?
Primarily children between 5 and 15 years old, which, lines up perfectly with the peak age for GAS pharyngitis itself.
But the incidence varies wildly across the globe.
Dramatically so. In many developing countries, you might see rates well over 50 per 100,000 children. And in some indigenous populations, like in parts of Australia, it can be incredibly high, maybe 150 to almost 400 per 100,000.
Compared to industrialized nations where it's maybe 2 per 100,000, or even less.
Exactly. Less than or equal to 2, often. And these huge differences really point to factors like socioeconomic status, overcrowding, which helps GAS spread, and of course access to healthcare and antibiotics.
It really highlights those social determinants of health. But why do we see such stark differences, sometimes even within the same country? It leads us to the pathogenesis. It's not the bacteria directly damaging the organs, right?
You've got it. ARF is an immune-mediated disease. It's the body's own immune response going awry. The core concept is something called molecular mimicry.
Okay, explain that a bit more simply.
So, your immune system creates antibodies to fight the strep bacteria, targeting parts like the M protein on its surface. But in certain people, these antibodies get, well, confused. They mistakenly recognize similar-looking molecules, epitopes, on the person's own tissues.
Ah, so they cross-react?
Precisely. They cross-react with tissues in the heart, the joints, sometimes the brain. For example, parts of the GAS-M protein look very similar to proteins in human heart muscle, like myosin or tropomyosin.
So the antibodies attacking the strep also end up attacking the heart muscle, like friendly fire.
That's a great analogy. Friendly fire. These cross-reactive antibodies, along with T cells, infiltrate these tissues and cause inflammation. In the heart, this can lead to things like Aschoff nodules, which are characteristic findings in the heart valves. And this whole immune process explains that delay, that latent period between the strep infection and ARF symptoms.
Okay, that makes the mechanism clearer. So when a child does present, what are the clinical features we should be looking for? I know there's one single sign.
Right. Diagnosis relies on a pattern, which is why we have the Jones criteria. But generally, ARF presents in 2 main ways. The most common form, maybe 70–75% of cases, is an acute illness with fever, joint problems, and often carditis.
And the other form?
It is more of a neurological or behavioral thing dominated by Sydenham, Chorea. In these cases, joint issues are usually absent, and any carditis might be subclinical, meaning you only find it with an echocardiogram.
Got it. Let's walk through the key features, starting with the 5 major criteria from Jones. Arthritis seems like the most common one.
It is, yeah. Seen in about 3/4 of patients, the classic picture is a migratory polyarthritis.
Migratory meaning it moves around.
Exactly. It typically hits large joints, knees, ankles, wrists, elbows. A joint gets really hot, red, swollen, and incredibly painful.
Yeah.
But then within a day or two, it might start getting better while another joint suddenly flares up. It migrates. Importantly, this arthritis usually resolves completely, leaving no permanent joint damage.
And there's a clinical pearl here about treatment response, right?
Yes, very important. It typically responds dramatically to salicylates like aspirin or nowadays more often NSAIDs. If you give anti-inflammatories and the arthritis doesn't rapidly improve, you should seriously question the ARF diagnosis.
So sometimes holding off on the NSAIDs for a day or two might actually help diagnostically to see if it migrates.
It can be prudent, yes, especially if the presentation isn't perfectly typical. You can use acetaminophen for pain and fever control during that observation period.
Okay, next major criterion, and the most serious, carditis.
Absolutely. This occurs in maybe 50–60% of patients, and it's responsible for almost all the long-term problems and mortality associated with ARF. It's often described as pancarditis.
Meaning inflammation of all layers of the heart.
Potentially, yes. The endocardium, which lines the chambers and valves, the myocardium, the heart muscle itself, and the pericardium, the sac around the heart. But the most critical component clinically is usually valvulitis inflammation of the heart valves.
Particularly the mitral and aortic valves.
Correct. Mitral regurgitation is the most common finding. You might hear that typical apical holosystolic murmur that radiates towards the axilla. Aortic regurgitation can also occur, often heard as an early diastolic murmur along the left sternal border.
And a big change came with the 2015 Jones criteria update regarding carditis.
Yes, a very important one. The criteria now officially recognize subclinical carditis. This means evidence of valvulitis seen only on an echocardiogram, even without an audible murmur, counts as carditis.
So echo is really key.
It is essential. One other point. If you see signs of myocarditis or pericarditis without any evidence of valve involvement, it's less likely to be purely rheumatic. You should think about other causes too.
Good point. Okay, third major criterion. Sydenham chorea or St. Vitus dance?
This one's quite distinct. It affects about 10–15% of patients. It's a neurological disorder presenting with abrupt, involuntary, non-rhythmic movements. Think jerky or writhing motions. There's often muscle weakness and emotional ability too. Kids might cry easily or seem unusually irritable.
And this has the longest latency period.
It does, sometimes appearing months after the strep infection. It can even be the only sign of ARF. Clinically, you might notice things like a milkmaid's grip when they try to squeeze your fingers. Their grip strength waxes and wanes involuntarily. Or spooning of the hands when held outstretched, or darting movements of the tongue.
Do the movements happen during sleep?
No, characteristically they cease during sleep and often get worse with stress or when the child is trying to perform a task. The good news is it rarely causes permanent neurological damage.
Okay, two more major criteria, both pretty rare. Erythema marginotum.
Very rare, less than 1% of patients, but highly specific if you see it. It's a rash, pink or reddish, non-itchy macules, often with pale centers and wavy serpentine borders.
Where does it usually appear?
Mostly on the trunk and the parts of the limbs closer to the trunk. Importantly, not on the face. It can be subtle and often brought out by warmth, like after a bath. It's also described as evanescent.
Meaning it comes and goes.
Exactly. It can appear, fade, and reappear over hours or days.
And the last major one, subcutaneous nodules.
Also very rare, again, less than 1%. These are small, firm, painless lumps, maybe 1/2 centimeter to 2 centimeters across, found under the skin.
Where typically?
Usually over bony prominences or tendons, elbows, knees, knuckles, sometimes the scalp or along the spine. Their presence often suggests more severe underlying carditis.
Okay, those are the 5 majors. Now the 4 minor criteria, these are less specific, right?
Correct. They help support the diagnosis when you don't have 2 majors. The first is arthralgia.
Just joint pain without the swelling and redness of arthritis.
Right. In low-risk populations, it has to be polyarthralgia, multiple joints. But in moderate or high-risk areas, even monoarthralgia, 1 joint can count. But you can't count arthralgia as minor if you've already counted arthritis as major for that patient.
Makes sense. Second minor, fever.
Yes, and the threshold depends on the population risk. For low-risk populations, it's a temperature of 38.5 degrees Celsius or higher. For moderate high risk, it's slightly lower, 38.0 degrees Celsius or higher.
Again, making it easier to diagnose in high prevalence settings. Third minor, Elevated inflammatory markers.
Yep, the acute phase reactants, specifically ESR and/or CRP. For low-risk groups, the cutoffs are an ESR of 60 millimeter or more, or a CRP of 3 milligdl or more. For moderate high-risk groups, the ESR cutoff is lower at 30 millimeter or more, while the CRP cutoff remains 3 milligdl or more.
And the final minor criterion.
A prolonged PR interval on the ECG, but only if it's seen in the absence of carditis being counted as a major criterion. It's important to note that a long PR interval by itself doesn't confirm carditis or predict long-term heart problems.
So what does this all mean for making a definitive diagnosis? How do we synthesize all this using the Jones criteria?
Right, the Jones criteria, updated in 2015, are our guide. Their goal is to help diagnose accurately and avoid overdiagnosing ARF. The absolute foundation, the prerequisite for almost all cases, is evidence of a preceding Group A strep infection.
Except possibly for Chorea, because of that long delay.
Exactly. For Chorea presenting late, the antibody levels might have already returned to normal. But for others, you need proof. Either elevated or, even better, rising ASO or anti-DNase B titers, a positive throat culture for GAS, or a positive rapid strep antigen test. Given the delay, serology, the antibody test, is usually the most helpful.
Okay, so you have the proof of strep. Then what are the rules?
For an initial episode of ARF, the diagnosis requires either 2 major criteria or 1 major criterion plus 2 minor criteria.
And for someone who's had ARF before, a recurrence.
The criteria are slightly more lenient for a recurrent episode. It's 2 major or 1 major plus 2 minor, or just 3 minor criteria.
And you mentioned the risk stratification introduced in 2015. How does that play out in practice?
It's really important. It acknowledges that ARF behaves differently and is much more common in certain populations. So places like the US, Canada, Western Europe are generally considered low risk. Many parts of Africa, Asia, the Pacific, and indigenous populations in countries like Australia or New Zealand are considered moderate or high risk.
And the criteria differ slightly.
Yes, mainly in the minor criteria definitions, like the lower fever and ESR cutoffs we mentioned, and also allowing monoarthritis or polyarthralgia to count as major criteria in the moderate high-risk groups. This increases the sensitivity of the criteria in places where ARF is more common, helping to catch more cases.
That seems like a sensible adjustment. And you emphasized cardiac evaluation for everyone.
Absolutely critical. Every patient suspected of having ARF needs cardiac evaluation, usually including an echocardiogram, regardless of whether they have an obvious murmur or symptoms of carditis. We need to look for that subclinical involvement.
Are there any exceptions where the strict Jones rules might not apply?
There are a few recognized situations. One is isolated chorea, where it's the only major sign. Another is indolent carditis presenting very late, maybe months after onset, as the only finding. And some recurrent cases in high-risk settings might be diagnosed based on clinical judgment, even if they don't perfectly meet the criteria.
Okay, so when we suspect ARF, what are the key investigations we need to order?
Well, first and foremost, evidence of that strep infection. So ASO and anti-DNase B titers are crucial. Checking both increases your detection rate significantly, over 95% pick up a recent infection compared to maybe 80–85% with ASO alone. A rising titer over time is the strongest evidence.
What about the throat culture or rapid test?
You should do them, but remember, they're often negative by the time ARF symptoms appear, maybe in 75% of cases. So a negative result doesn't rule out ARF at all.
Got it. Inflammatory markers.
Yes, CRP and ESR. You expect these to be elevated, reflecting the systemic inflammation. They help support the diagnosis and can be monitored to track response to treatment. CRP usually normalizes faster than ESR. The only exception might be isolated chorea, where they can sometimes be normal.
And for the heart?
Echocardiogram is indispensable. It diagnoses both clinical and subclinical carditis, identifies which valves are affected, usually mitral and/or aortic regurgitation initially, and assesses the severity of the damage and heart function.
And an ECG.
Yes, mainly to look for that prolonged PR interval, which can be a minor criterion, but also for any other signs of myocarditis or pericarditis, like ST changes or arrhythmias, although those are less specific to ARF itself. A basic blood count might also show a high white cell count or mild anemia.
Given the variety of symptoms, ARF must have a pretty wide differential diagnosis. What other conditions often get confused with it?
It can definitely be tricky. When arthritis is the main feature, juvenile idiopathic arthritis, JIA, is a big one. But JIA arthritis is typically less migratory, less acutely painful relative to the swelling, and doesn't respond as dramatically to salicylates. Plus, Kids with JIA might have other features like high spiking fevers, a characteristic rash, or enlarged lymph nodes or spleen.
What else mimics the arthritis?
Things like systemic lupus erythematosus, SLE, look for other systemic signs and specific antibodies like ANA. Septic arthritis is usually monoarticular and much more severe locally. Malignancies like leukemia can cause bone pain. Serum sickness, Lyme disease, sickle cell vaso-occlusion, even reactive arthritis after infections like Shigella or Salmonella.
What about post-streptococcal reactive arthritis, PSRA? That sounds very similar.
It does, and it's a bit controversial. PSRA usually occurs sooner after strep, 1 to 2 weeks. The arthritis tends to respond poorly to aspirin, and critically, true carditis isn't a feature. Some view it as perhaps a milder form on the ARF spectrum, but the Jones criteria are designed to distinguish ARF. If the criteria are met, it's ARF and requires the same management, including prophylaxis.
Okay. If carditis is the main or only feature.
Then you'd think about viral myocarditis or pericarditis, Kawasaki disease, especially in younger children, or even infective endocarditis, which you'd differentiate with blood cultures and looking for other signs.
And if chorea is the isolated finding.
The differential includes other causes of chorea, like Huntington disease, though usually later onset, Wilson disease, SLE affecting the brain, or certain types of encephalitis.
All right, so we've navigated the diagnosis. Let's talk acute treatment. What are the goals?
It's a multi-pronged approach. The main goals are 1. Eradicate any lingering GAS bacteria. 2. Relieve symptoms like fever and joint pain. 3. Manage any heart inflammation or failure or severe chorea. And 4. Start the process of preventing future attacks.
So step 1, get rid of the strep.
Absolutely. Every single patient diagnosed with ARF needs a course of antibiotics to eliminate GAS carriage from the throat, even if their throat culture was negative at diagnosis.
And the go-to is penicillin.
Yes, the first-line recommendation is usually a single intramuscular shot of benzathine penicillin G. This effectively treats any residual infection and conveniently also serves as the first dose of their long-term secondary prophylaxis.
What if an injection isn't possible or the patient is allergic?
Oral options include a 10-day course of penicillin V or amoxicillin. If there's a penicillin allergy, you can use a macrolide like erythromycin for 10 days, azithromycin for 5 days, or clindamycin for 10 days.
Okay. Now, managing the arthritis and fever.
NSAIDs like naproxen or ibuprofen are generally preferred now over aspirin. They work well, have fewer side effects, and usually require less frequent dosing. Aspirin is still an effective alternative.
How long is treatment needed?
Usually until the symptoms resolve and those inflammatory markers, ESR, CRP, start coming down. The response is often quick, within 48 hours, but sometimes treatment needs to continue for several weeks, maybe 6 to 12, sometimes with a slow taper, especially if symptoms try to rebound.
And remember that diagnostic pearl holding off NSAIDs initially if the arthritis pattern isn't classic.
Right, using acetaminophen for comfort while observing.
What about managing severe carditis, especially if there's heart failure?
That's when corticosteroids, like oral prednisone, are indicated. They help reduce the inflammation more powerfully than NSAIDs. These patients also need supportive care diuretics to manage fluid overload, maybe salt and fluid restriction, oxygen if they're hypoxic. And just a note, if digoxin is considered for heart failure, be aware its toxicity risk is higher with myocarditis.
And treatment for chorea.
It's often mainly supportive care, providing a calm environment, because it usually resolves on its own over weeks to months. Anti-inflammatories aren't typically needed unless there are other ARF symptoms. For severe or very disruptive chorea, medications like sedatives, phenobarbital, or sometimes drugs like haloperidol or valproic acid might be used carefully. Corticosteroids are also sometimes considered for a few weeks in difficult cases.
So while the arthritis and chorea usually get better without lasting effects, the heart is the main long-term worry.
Precisely. Which brings us squarely to prevention.
The cornerstone of long-term management. Let's start with primary prevention.
Primary prevention means stopping that first episode of ARF from ever happening. The way to do that is by promptly diagnosing and properly treating group A strep pharyngitis with antibiotics. Treatment started within about 9 days of sore throat onset is highly effective at preventing ARF.
But the big challenge here is silent or missed infections, right?
Exactly. Many ARF cases follow strep infections that were either subclinical, no significant symptoms, or simply weren't recognized and treated. That's why primary prevention alone isn't enough, and secondary prevention becomes so critical for anyone who's already had an episode.
So secondary prevention is about stopping recurrences in patients with a history of ARF.
Yes, because we know that people who've had ARF are at much higher risk of getting it again if they have another GAS infection. And each recurrence tends to increase the risk and severity of permanent heart damage, rheumatic heart disease, RHD.
What's the preferred method for secondary prevention?
The gold standard is regular intramuscular injections of long-acting benzathine penicillin G, usually every 4 weeks.
Why injections?
Because adherence is guaranteed. With oral antibiotics, missed doses are common, which leaves the patient unprotected. In very high-risk situations, or if someone has a breakthrough recurrence despite 4-weekly shots, sometimes the injections are given every 3 weeks.
Are there oral options if injections really aren't feasible?
Yes, though they rely heavily on adherence. Options include oral penicillin V twice daily, or sulfadiazine, or sulfasoxazole, once daily. For those allergic to both penicillin and sulfa drugs, macrolides like erythromycin can be used, though data might be less robust.
Okay, the duration. This is where it gets complex depending on the patient's history. How long does this prophylaxis need to continue?
It's long-term, often for many years, and depends on cardiac involvement. For someone who had ARF without any carditis, prophylaxis should continue for at least 5 years after their last attack, or R until they turn 21 years old, whichever period is longer.
And if they did have carditis, but it resolved completely with no lasting heart valve damage?
Then the duration is longer, at least 10 years since the last attack, or R until age 21, again, whichever is longer.
What about the most serious group, those with carditis and residual heart disease, like persistent valve problems seen on echo?
For them, it's generally recommended for at least 10 years since the last attack, or R until they reach 40 years of age, whichever is longer. And for many with significant valve disease or those living in high-risk environments, lifelong prophylaxis is often necessary.
Lifelong, wow.
Yeah.
Even after valve surgery.
Yes, prophylaxis should continue even after valve replacement or repair. And crucially, anyone who had Sydenham chorea, even if that was their only symptom, needs long-term prophylaxis, just like someone with carditis, because the risk of developing RHD later is still there.
That's a huge commitment for patients and families. What are some practical notes for helping them manage this?
Absolutely. First, reinforcing why it's so critical. Remind them that the long-term danger of ARF is almost entirely about the heart, leading to RHD. The other symptoms resolve, but protecting the heart requires sticking with prophylaxis. Continuous adherence is the single most effective way to prevent RHD progression.
How can we support adherence, especially with the injections, which can be painful?
We need to actively manage injection discomfort. Use proper technique, maybe the ventrogluteal site, which can be less painful. Consider mixing with a local anesthetic like lidocaine if protocols allow. Use distraction, ice packs, things like that. Make the experience as tolerable as possible.
Access is also key.
Definitely. Can it be delivered at school? Can appointments be made easy, maybe with reminders? Reducing barriers is huge. And education is paramount, making sure the patient and family understand this isn't optional, even when they feel perfectly well years later.
Any other practical tips?
Yes, advise them that if they get a sore throat while on penicillin prophylaxis, it should probably be treated with a non-penicillin antibiotic to cover potential resistant organisms or non-strep causes. Also emphasize good dental hygiene, because damaged heart valves are more susceptible to infective endocarditis.
So, if prevention efforts fall short, what are the main long-term complications we worry about?
Two main things: recurrence of ARF itself and the development or worsening of rheumatic heart disease. Patients are most susceptible to recurrence in the first 5 years after an attack, but the risk persists.
And RHD is the big one.
It is. It's the chronic damage to the heart valves that develops over years, maybe 10, 20 years after the initial illness, but sometimes faster with severe or multiple episodes. The mitral valve is most commonly affected, often starting as regurgitation, leakiness, which can eventually progress to stenosis, narrowing. And every recurrence of ARF can worsen the existing heart damage.
Okay, let's unpack this. We've covered the crucial link between strep throat and ARF, the complex immune mechanisms at play, the molecular mimicry, and the diverse clinical presentations: arthritis, carditis, chorea, the rashes, nodules that demand our careful attention using the Jones criteria. We also detail the investigations and the multi-pronged approach to treatment, including that vital long-term prevention.
Right. And if we connect this to the bigger picture, I think the real take-home message for all of us in healthcare is crystal clear. Early recognition of strep throat, prompt treatment to eradicate the group A strep, and then for those who develop ARF, vigilant, truly long-term secondary prevention. These are the most powerful tools we have. They're what stand between a child and the potentially devastating consequences of rheumatic heart disease. It really is about protecting those young hearts from what is ultimately a preventable disease.
That's all for today's topic on acute rheumatic fever in children. Thank you for joining the podcast. And remember, the key to reducing ARF's burden is early recognition and prevention. If you found this video helpful, give it a like, subscribe to the channel, and share it with your colleagues and friends so more people can benefit. Stay tuned for our next topic.